Yes, sir. I'm here, sir.
Okay. We are live now. And welcome to Cardiac Symposium for this year. We had a few cardiac symposiums during the COVID time, but this is our first one since the COVID. And today, I'll be handing over the proceedings to Amarja, who is going to take you through this symposium. We have faculty from US with Professor Kathirvel, and faculty from India, Professor Minati, and we also have Dr. Akhilesh. And so I would be handing over to Amarja. Amarja, over to you.
Yes, sir.
Let me stop sharing the screen. Yeah.
Yes.
Yeah.
Good evening, everybody. And today, this is the first session of Cardiac Symposium. And we have very eminent speakers with us for this day. The first speaker is Dr. Kathirvel Subramaniam. He needs no description. We all know him. He's Professor, Director, Perioperative Echocardiography Education and Training Undergraduate School, Coimbatore. And he has been trained at Coimbatore Medical College, India. And at present, he is cardiac anesthesiologist at Beth Israel Deaconess Medical Center, Harvard Medical School, Cleveland Clinic. And his special interests are cardiac anesthesia, echocardiography, and medical education. He is talking on a very important topic, that is ERAS, and he'll be also including lung isolation techniques and one lung ventilation in his talk. So over to you, Kathirvel, sir.
Thank you, Amarja. So thank you for the kind introduction. Good morning, good evening, good afternoon to everybody. Here it is 9:30 a.m. I'm sure wherever you are, thank you for joining. So today I'm going to talk about enhanced recovery after thoracic surgery. The ERAS has taken off in recent times. When somebody asks what is ERAS, it is there is a scientific definition, obviously, an evidence-based pathway that utilizes multimodal and interdisciplinary approach to perioperative care that designated to decrease the time required to recover from surgery and improve patient outcomes. So there are keywords in each and every thing which I mentioned. But in a shorter term, the ERAS is just doing the right thing and decreasing the variability between the providers. Those are all the two key aspects. So as I mentioned, variation between providers should be avoided by protocolized approach to patient care. So it's not a disorganized traditional approach. Any medication can be given, any dose can be given. You're not really worried about outcomes. You're not really worried about complications, length of stay. But here, ERAS approach takes into account common pathway, decreasing variability, and then providing better outcomes. So that's the primary key point. And second thing, the protocols you develop should be based on best evidence. Obviously, the best evidence come from individual clinical expertise, best external paper-based evidence, and the patient values and expectations. So you have to be practical. You cannot just depend on manuscripts and journals and papers. It has to be tailored to the patient. It has to be combined with individual clinical expertise, because you may not find evidence for many areas we are going to practice. The number 3 key point is it is not an anesthesiologist alone. It has to be ICU physicians, a surgeon, registered nurse, floor nurse, you have pharmacy, IT, project managers, all involved in this development of protocols. So everybody has an engagement to do the right thing for the patient in a comprehensive way, not just intraoperatively. Number 4, when you develop protocols, compliance with the protocol is so important. So you can have a protocol if you have only 20% of people compliance with it. The outcomes may not be significantly different. So improving the compliance happens over time. When you start these protocols at our institution, also we have a lot of questions, we have a lot of variations. Then over time, people realized, this is the right way to go. So time will, improve the compliance. Improvement in compliance will be associated with better outcomes. And number 5, since there is no solid evidence for all what you practice and what you develop as a protocol too, you may not have a strong evidence. It is important to monitor the data of your own protocols of 6 months or 1 year, and then develop outcome data-driven care. So if you find a drug, let us take ketamine, you use for analgesia, and then it did not improve any analgesia compared to your historical control, then that means the ketamine is not helping. So you need to have data of pre and post, or between between 2 different protocols, so that you can compare and contrast and develop the best practice protocols ultimately. So protocolized approach, protocol based on evidence base, multidisciplinary comprehensive approach, develop compliance with the protocol, and then monitor the data, and the data should modify the protocols in a servo fashion. So we developed UPMC 2015 ERAS at our University of Pittsburgh. So we compared and published our results in 9,492 patients. The enhanced recovery pathway was 5,000 patients, and controls were around 4,000 patients. So we reported improved outcomes in 30-day mortality, 1-year mortality, 2 years length of stay, and discharge to facility. So it's significantly different pre-ERAS and post-ERAS. So this data can be shown to hospital administration to gain additional support for your development of further protocols. For example, these protocols involved orthopedic surgery, colorectal surgery, major abdominal surgery. So based on these results, the hospital supported us to develop further protocols in thoracic surgery or cardiac surgery, or those areas where the ERAS has not been developed. So it's important to have a data published so that the hospital administration, even your colleagues, appreciate what you do. So coming to the mechanism of ERAS, whenever there is a surgical stress, it disrupts completely homeostasis. So when you develop ERAS protocols, it is aimed towards attenuating surgical stress response and accelerate post-operative recovery. This is the hypothesis. I didn't see a strong evidence to say that the ERAS protocols suppress surgical response, except maybe a paper in abdominal surgery. But this is the hypothesized, hypothesis of the ERAS protocol. ERAS pathway has to be very comprehensive. It has to be start from preoperative phase, continued into intraoperative and postoperative, and we will go through each and every protocol in detail. First, we start with prehabilitation. So the ERAS is not intraoperative. There is confusion in the among people that ERAS is mostly with multimodal analgesia. That's really not true. ERAS protocol starts with preoperatively preparing the patient. So preparing the patient means, first of all, you see the patients. As anesthesiologist, you have to see these patients preoperatively. When it doesn't need, it is used to be one day before you go and do pre-op and then advise what you want. Nowadays it's changed. Anesthesiologists run preoperative clinic. They see the patient 4 weeks before or 8 weeks before, during which time you continuously work with the patient, work with the surgeons to improve what can be done for the patient to prepare best for the surgery. So the best thing which helps patient is education. So if you will be surprised, the patient come to the preoperative holding area without any knowledge of what they are going to go through. So that education is never done by nurses, never done by surgeons. It is your responsibility. You have an opportunity to master that education part and help the patients. When they understand better, their anxiety levels are low and the outcomes are better. So now, what are the things you do preoperatively? If you look at these arrows, the high level of evidence is there for weight loss and nutritional support. Number 2, smoking cessation. Number 3 is anemia treatment. There are other things we can do. You can do alcohol screening, alcohol management, pulmonary rehabilitation, cardiac rehabilitation. But these 3 has a solid evidence to support we should be doing in all patients. You have to optimize nutrition. You have to make sure smoking cessation is done. You have to treat anemia. These 3 things have strong evidence to suggest that we have to practice them. But otherwise, all the other things are still in development. They are good things to do. There may not be solid evidence, but we have to develop evidence based on our practice. Now, pre-op assessment. It goes through a lot of scales and scores and things like that. You don't do everything to the patient. Most practical things you have to do. One thing I recommend people do is clinical frailty scale. Any frailty is nothing but, are they, not only the surgical site, other parts of the body is ready for surgery. That's what you assess through frailty. Frailty scales are multiples. You may find 10, 15 scales in clinical practice, but you develop something which is easy to use, like clinical frailty scale. Other things we do typically is METS, metabolic equivalent task, daily routine activity, how much a patient can do, and then risk score the pulmonary system, risk score the cardiac system by revised cardiac risk index, which all of you know. We use ARISCAT score based on age, preoperative saturation, preoperative hemoglobin, emergency surgery or elective surgery, what is the incision site, respiratory infections present or not. So we develop a score and predict what is the percentage of pulmonary complications the patients will develop. Nutrition, as I told you, assessment of nutrition should take into account BMI, weight loss. A simple question: did you lose appetite? Did you lose weight? And then corroborate with albumin levels or pre-albumin levels. So those are all the easiest things you can do to assess. It doesn't need to be an extensive assessment, but a practical clinical assessment will help you to grade the complication rate which will develop after surgery. Nutritional support. Once you know the patient is having malnutrition or borderline nutrition, it is your responsibility to recommend calorie intake, protein intake, other elements intake. There are protocols, there are pamphlets, there are internet-based algorithms which you can send through the online to the patients. So that's what we do at our preoperative clinic. Once we know the albumin level is low, the weight loss is, BMI is low, to prepare the muscle muscle mass for the surgery, to develop better immunity, we put up some nutrition plan for the patient. Sometimes we send the patients to nutritionists if that is required. Immune nutrition is something which we should know. Arginine, omega fatty acids, and nucleotides combined in a bag. We actually have something like fruity, all these things combined, and we give it as a package to the patients. We ask them to take 1 week before surgery, every 8 hours, one pack of, whatever you call it as impact or ensure, that improves the wound healing, that reduces inflammation and stress, that builds immune cells, prevent infection. So these are all some of the important components of immune nutrition, which you can provide to, get best outcome from the patient. Rehab measures, if we determine the patient's ejection fraction is low, the patient's PFT, pulmonary function test, shows the FE1 less than 60%, we send these patients for cardiopulmonary rehabilitation centers to prepare them before surgery. It is a typical practice. You have surgery and then start cardiopulmonary rehab post-operatively. But now we start pre-operatively. One, the patient gets used to it, and patient develop endurance, patient develop muscle training before all of them have been shown to decrease the post-operative pulmonary complications. What is the typical period you want to do? You usually have a 2 to 3 sessions per week, and then it lasts for 4 to 8 weeks. And then it has been shown to decrease the pulmonary complications after thoracic surgery. Anemia prevention protocols, I don't need to really go through in detail, but I can tell you, if you find anemia less than 13 or less than 12, look at the reticulocyte count to rule out hemolysis. And then, look at simple tests, MCV, MCH, to know whether it is a hypochromic microcytic anemia or macrocytic anemia or normocytic. That will tell you the etiology by itself. It is microcytic, it's most likely iron deficiency. Macrocytic, it's most likely vitamin B12 or folic acid deficiency. When you send hemoglobin, peripheral smear, they do this anyway. So normocytic, of course, will have to be dealt with based on the cause of anemia. So then, if you find microcytic picture, then you send iron levels and transferrin saturation. If the ferritin level is low, the transferrin saturation is low, the iron deficiency is confirmed, then you administer IV ion or oral ion based on the level of hemoglobin. If I find the patient's hemoglobin is 8 or 9, we actually put them on 4 to 5 weeks of iron therapy and develop the hemoglobin to more than 12 or 13 before the patient undergoes surgery. This is typically done by iron infusion centers in our hospital. They have, we just prescribe, anesthesiologist, we prescribe, and then the patient goes and have iron infusions in the preoperative center. And then, we check the hemoglobin before surgery. If the patient still have anemia, we refer them to hematologist for further planning. If the patient, hemoglobin increases, then go for surgery. So these things, this much preparation is included in ERAS protocols. The ERAS protocols are not only giving ketamine or giving blocks or anything else. So you prepare the patient for surgery, you educate the patient for surgery, you prehabilitate patient for surgery. These are all the important components, actually maybe the most important components of patient care. Now, coming to the prophylaxis, the venous thromboembolic complications can happen after major thoracic surgery. The one example typically is esophagectomies. So we should be very careful in looking at the venous thromboembolic risk. All of them get prophylactic heparin during and after surgery. As soon as the patient comes into the holding area, we give prophylactic 5,000 units of heparin before going into surgery. And then it is repeated every 12 hours. till the patient is ambulant or during the hospitalization. But if the patient's venous thromboembolic risk is very high, based on your factors like hypercoagulability diseases or limited mobility or massive obesity, then you have to think about continuing that prophylaxis for 4 weeks after surgery, because you may have a patient who may develop a venous thrombotic clot and PE 4 weeks, 3 to 4 weeks after surgery. So you should know which patient to stop during discharge, which patient you want to continue post-operatively. These are all, again, parts of enhancing recovery without complications. The infection risk, as you know, every surgery has a risk, so we have to make sure the antibiotic prophylaxis and skin preparation are done properly. The antibiotic has to be given within 60 minutes, but prior to incision. There's a strong evidence to suggest that this is helpful. We should know, again, which patient the antibiotics should be continued, which patient should be discontinued. Mostly we don't continue without an indication antibiotic prophylaxis post-operatively. If the patient is in ICU, they may get 2 more doses, but it is discontinuous typically in the post-operative period without any signs of infection. Coming to fluid management, this is intraoperative or postoperative fluid management is an important component of ERATS. Preoperative fasting guidelines has been revised. As you are all aware, clear fluids are allowed up to 2 hours before induction of anesthesia, solids until 6 hours before induction of anesthesia. There is a question whether the oral carbohydrate loading really helps post-operative insulin resistance or not. As you see, the evidence base is very low, but the recommendation is strong. You will see this in the ERAS protocols. Even though the evidence is low, based on their experience, they recommend strongly to have it. This is one of these, the oral carbohydrate loading. I can say you one of the meta-analysis done on this carbohydrate loading, including 43 trials and 3,000 patients. Carbohydrate loading before elective surgery conferred a small reduction in length of hospital stay compared with fasting. So if you compare the carbohydrate fluids compared to extended fasting, it is better. But if you compare to plain water, not carbohydrate water, there is no benefit has been shown. So the evidence for carbohydrate loading is weak. Still, people recommend this as a part of ERATS. Now, perioperative fluid management, you can always see controversies. You restrict fluids in lung surgery, give liberal fluids for major surgeries, give goal-directed therapy. So all kinds of recommendations are there, but the evidence for all these things are moderate. But yes, you see the recommendation is very strong. Balanced crystalloids are the intravenous fluids of choice, like plasmolite or ringer lactate, should be used in preference to 0.9% saline, which has been shown to increase the complications. And the saline load, the sodium load in saline is extremely high compared to balanced crystalloids. So the recommendation is evidence-based and strong. Intravenous fluids should be discontinued as soon as possible and replaced with oral fluids and diet. The evidence is again moderate. So preventing intraoperative hypothermia is, I put it along with fluid management, because if you give cold fluids, obviously you develop hypothermia, but hypothermia has other components. Maintenance of normothermia is really, really important, whether it is heart surgery, whether it is thoracic surgery or abdominal surgery. So these 3 components should be taken care together. And let's go through this fluids. How do you give fluids? The recommendation is to make the patient euvolemic. Don't make them dry. Don't make them, flooded. with fluids, a goal-directed hemodynamic therapy to achieve maximal stroke volume, maximal cardiac output, or oxygen delivery according to Frank-Starling relationship between cardiac preload and cardiac output. So if the theory is if you increase the preload, you increase the cardiac output, you increase the perfusion to the organs. So there is a Frank-Starling. Sorry, if you increase the preload, it increases the ventricular distension, it improves ventricular contractility, it improves the cardiac output. So that is the theory here to achieve a maximal. But at some point, if you give more fluids, the stroke volume and cardiac output may not increase. At that point, you don't want to give more fluids. So if you see a stroke volume responsiveness to fluids, you give fluids. If you don't see a responsiveness, you don't give fluids. You do something else to improve the blood pressure. So that's a basic theory of it. You can always say people who don't believe in these theories will go for a net zero balance. Give only 2 liters or 1.5 liters in 24 hours. Most commonly, this is utilized in the post-operative period. Intraoperative period, you can really use goal-directed therapy. Post-operative period, you can use a net zero fluid balance with, fluid intake, fluid output, monitor these things and administer a restrictive fluid to 2 liters and minimize the post-operative weight gain to 1 to 1.5 kilos. Will decrease the risk of lung edema. So fluid therapy is a very, very sensitive aspect of thoracic surgery. Here in VATS surgeries, mostly you can give up to 2 liters intraoperatively, even less than that. But in open surgeries like a pneumonectomy or you're doing a esophagectomy, then those patients will receive 7 to 8 liters of fluids intraoperative period. I have to say that it really, really depends on the patient. Patients with Trendelenburg position, reverse Trendelenburg position, there is a kind of laparoscopic air inside the belly, position in the left lateral position. All these things modify your stroke volume, your fluid status, your fluid shifts. There is no real monitor which we can use with 100% proof that this is going to show the real indication of cardiac blood volume. So it's really, you have to use your own knowledge with your experience, depending on patient factors to each patient. It's basically sitting with the patient, looking at the numbers continuously and planning the intraoperative fluid management is very, very important area. And anesthesiologists can really help this part. I have a lot of arguments with surgeons in the operating room when they ask for fluids unnecessarily. I have a better ways of improving blood pressure. There is always argument. Don't, give a lot of fluids. Don't give vasopressors because vasopressors decreases microvascular blood flow and causes anastomotic leak. And so these are all the arguments the surgeons will come up with. So use the best evidence, use the best experience to counter the surgical team and, guide the patients for proper therapy. Unfortunately, I cannot tell you this is what in white and black because your experience plays a lot of, a lot play in this area. So if you goal-directed fluid therapy is recommended when you have a high-risk patient for low-risk surgery or high-risk surgery. When you have a patient low-risk for low-risk surgery, for it's example you are doing a wedge resection, your goal-directed fluid therapy may not be indicated at all. You can go with a zero balanced fluid management. But if you have a low-risk patient, like no cardiac disease, but you have a high-risk surgery like a lobectomy or pneumonectomy, then you can do goal-directed fluid therapy. If you have a high-risk patient for low-risk surgery, you have a cardiac disease patients undergoing a lobectomy or wedge resection, then you can do goal-directed fluid therapy. obviously high-risk patient, high-risk surgery, in addition to goal direct therapy, consider post-operative ICU care. So it depends on the patient risk and surgical risk. This is a trial in abdominal and major surgical patients, low risk to moderate risk surgical patient. I won't say this is a pneumonectomy patient, so, they did this study. But this study is the prospective evidence of 230 patients in each group to show that goal-directed fluid therapy decreased the post-operative complications. They did a good outcome study and have shown decreased kidney failure, decreased respiratory distress syndrome. So I think it is worth going through this paper, which is a positive evidence, which is a prospective randomized clinical trial, which has proven that I think they used esophageal Doppler, if I'm correct, as to guide the fluid therapy. Anesthesia technique. This also has a lot of, this is a part of it. As I described, anesthesia technique, analgesia technique is a part of ERAS protocol. It's not everything. So what we do in our institution, we don't administer midazolam or diazepam routinely to reduce anxiety, especially in older patients. We use lung protective strategies during one lung ventilation. A combination of regional and general anesthetic is used in most thoracic surgical patients. Whether to use, I will go through this IV inhalation drugs, whether it makes any difference. PONV is very annoying for the patient. Patients can pay a lot to avoid this complication. There is evidence to suggest PONV is the main driver for patients not satisfied after surgery. So we have to take all the measures. First of all, you have to assess the risk for PONV. So what is the risk for PONV? If it is high risk, low risk, then you treat this patient accordingly. There is a universal protocol irrespective of the risk. But if you have a high risk patient, okay, why not you run propofol infusion? Why don't you avoid narcotics completely? Why don't you do a goal directed fluid therapy? Administer, multiple drugs for prophylaxis. So you do everything, but the important aspect here is assessment of PONV risk is important. So regional anesthesia and pain relief is a major part of, ERAS protocols. As you know, different institutions have different blocks they use. I'm not going to compare this versus that. What works best for you, what you are best at, you should practice. For example, we used to practice epidural in olden days. We no longer practice epidural for all the patients nowadays. When you practice every day, you are best at it. Now, when you use selectively once in a month, you are not good at it. So that's what driven the epidural out of the picture. Now people are doing alternative regional anesthetic methods or analgesic methods like serratus anterior block or erector spinae block. I will say the evidence to support these blocks are weak. The most important thing is there is no endpoint. Though you use ultrasound, the variability depending on the patient factor, depending on the provider factor is huge. So I will suggest go for a neuraxial block, either a paravertebral block or an epidural block or an intrathecal block. If possible, you can supplement those blocks with any kind of additional peripheral nerve blocks like an intercostal block, a pleural block, or something like that. So at our institutions, we use intrathecal analgesia. We use epidural in selected patients. We also use paravertebral widely, which is practiced by the pain team exclusively. And the surgeons always give intercostal block for lung surgery patients. Multimodal analgesia, there is no question about it. You have to use it. Tylenol, NSAIDs, ketamine, the evidence is here and there. You can see the evidence is moderate. Dexamethasone, again, evidence is low. Say, if you give a good regional analgesia with some elements of multimodal analgesia like Tylenol, NSAIDs and some ketamine. I think that usually takes care of patient pain very well. Inhalation agents are IV agents for one lung ventilation. So there is a systematic review on this 38 randomized trial examining this concept. So here is the thing. So if you have inhalation agents are better than IV agents to reduce alveolar or systemic inflammation. Inhalation agents are better than IV agents for systemic hemodynamics. However, if you have a patient developing intraoperative shunt and oxygenation issues on one lung ventilation, IV agent propofol is better than inhalation agents. So postoperative pulmonary complications, no sufficient evidence one is superior to other techniques. So ultimately, what is happening intraoperatively drives your administration of anesthetic. If your patient is high potency, you don't want to really give a propofol infusion. So if you think the patient is developing pulmonary edema, probably the inhalation agents may protect the inflammation. If the patient has hypoxemia, maybe a propofol is a better choice. So you, depending on how the patient behaves, you pick and choose whether inhalation or IV. Long-term outcomes, no difference. Short-term outcomes, no difference. Tidal volume, this is another area discussed in lung surgery, whether to give a low tidal volume less than 6 or high tidal volume more than 8. So the difference here is no difference in oxygenation, no difference in lung compliance, no difference in length of stay. However, there is difference in pulmonary complications when you use low tidal volume ventilation. This is again 18 studies with more than 3,000 patients, randomized clinical trials have shown odds ratio is 0.4 for low tidal volume ventilation compared to high tidal volume. This is less than 6 and more than 8. So there is fair evidence to say low tidal volume should be utilized in clinical practice. And part of this talk also includes lung isolation. I will go through it briefly. So there is a lot you can talk about for an hour on this topic. So you typically double lumen tubes are used for lung isolation in thoracic surgery. Still, in a survey that they have done in Europe, they still found, majority of the anesthesiologists still use double lumen tube, though there is a rise in bronchial blockers practice. It is more you comfortable with the bronchial blocker, more you will use it. But there is some specific indications for double lumen tubes where you cannot use bronchial blockers. And bronchial blockers possess a lot of advantages when you can use it. So that's all I can say about double lumen tubes. Still have a place. So still people use it commonly, number one. Still it has a place. But bronchial blockers definitely have an advantage in selected patients. So here is the comparison. So double lumen tubes, if you have to frequently suction the patient, if you have a blood in the airway, if you have pus in the airway, if you have extensive secretions, double lumen tube is the preferred choice. So if you're isolating the lung for an empyema, or if you have a lung infection, pneumonia, or a tumor bleeding, then it is better to use double lumen tube. It is also used to secure damaged airways. When you have a bleeding, if you want to isolate, bleeding airway, then it's better to use a double lumen tube under vision. There is a less risk of displacement, easier to correct position with fiber optic bronchoscope. These things can be argued. With experience, you can even do these things with the bronchial blocker. This is, you can say, the less interference with surgical manipulations. It's easier to convert total lung ventilation to one lung ventilation. It's easier to apply CPAP to the non-dependent lung. It's possible to produce differential lung ventilation based on the lung pathology. People in AIMS know that you can always insert without fiber optic bronchoscope. In olden days, we did that and checked with auscultation. Now with fiber optic bronchoscopy, it made our life easier. But bronchial blocker, blind insertion may not be possible. Size selection is always, kind of problem with double lumen tubes. You have to know the size of the left main bronchus by CT to appropriately size the double lumen tubes. But practically you will know 37 you can use for women and 39 for normal size built adult men. So that kind of guideline you can use, even though adequate size selection needs a bronchial sizing. Bronchial blockers are advantageous, obviously, in difficult airways. You don't need to change the tube. You don't need to, at the end of the page, at the end of the case, if you have a lot of edema, it's difficult, dangerous to change the double lumen tube into single lumen tube. That's the kind of single most advantage I see of bronchial blockers. If you have a tracheal bronchus or abnormal anatomy, you can't use double lumen tube. You can use bronchial blocker. You can use with the nasal intubations. Definitely, compared to double lumen tube, there is less risk of injuries, less cuff damage. CPAP is questionable with bronchial blockers. Some of them have a port where you can give CPAP, but it's not effective that well like double lumen tubes. So as I told, main advantage is airway exchange at the end of the case. So what do you do? Typically, when you have indication like hemorrhage, or you have a bronchoalveolar lavage, you have a bronchopulmonary pleural fistula, or tracheobronchial tree injury, or you have a bulle or lung transplantation, differential ventilation is required, then you use double lumen tube still. So any secretions, any blood, any pus, or differential ventilation, you still use the double lumen tube as the preferred method. If you have a pneumonectomy, sleeve resection, or tumor obstructing the mainstem bronchus, you still use double lumen tube rather than bronchial blocker. Other indications like lobectomy, esophagectomy, you are doing a spine surgery, anterior spinal resections, you are doing a minimally invasive cardiac surgery, a robotic mitral valve repair. The double lumen tube is as good as bronchial blocker, or bronchial blocker is as good as double lumen tube. So you use based on the patient. If I see a patient who is 300 pounds, difficult airway, I will put a single lumen tube. I will use a bronchial blocker for these cases. But if I see an ideal airway, then it is a preference of the resident or fellow whom I'm working with. Whatever they want, they can do it. But if I have a real indication for double lung isolation, I still continue to use double lumen tube. So I will say in my practice, 90% of them were double lumen tubes, maybe 5 years back. Now I will say it's 50-50. 50% of patients I use bronchial blocker, 50% I still use double lumen tubes. So it depends on the indication, it depends on the patient. So the ERAS, not only anesthesiologists contribute to outcomes, the surgeons also involved in contributing to outcomes. You can use a minimally invasive thoracotomy, VATS approach. It is better, but most of our surgeons do lobectomies, wedge resections, everything through VATS approach, as unless it is thoracotomy is needed. If thoracotomy is required, a muscle sparing technique is preferred, nerve sparing technique is preferred to have a better outcome, to have a better pain relief, to have a better long-term outcome. You need to have a muscle sparing and nerve sparing surgical technique. The post-operatively, some of the surgical management also come to play. The chest tube should come out as soon as possible. They use air leak as the criteria for removing the chest tubes. You don't want to use the serous effusion volume as an indication for keeping the chest tube. So you want to remove the chest tubes as soon as possible, even if there is a fluid coming out of it. But if there is an air leak, you may want to keep it. So urinary drainage, again, it's not indicated in most patients undergoing thoracic surgery. Even if you put it in, you want to remove it as soon as possible. The aim is to get the patient out of central lines, out of arterial lines, out of chest tubes, out of urinary catheter, so that the patient can be mobilized within 24 hours of surgery. So if you have a patient high risk, this patient is going to end up in ventilation, you may use a prophylactic mini tracheostomy in certain high risk patients. It is very rarely done in our institution. We always try to wean the patient and then do tracheostomy post-operatively. You will be surprised, atrial fibrillation is a very common complication, like 25% after thoracic surgery. So it's important to pay attention to beta blockers. If they are taking beta blockers, you want to continue them intraoperatively and post-operatively to avoid atrial fibrillation. If the patient is not on beta blockers, then you want to discuss the initiation of beta blockers, at a preoperative phase, when the patient comes for CPC clinic or pre-op clinic to prevent atrial fibrillation, depending on the risk factors. Magnesium supplementation, monitoring magnesium levels and magnesium supplementation is also part of preventing AFib. Whether to administer amio or other prophylactic arrhythmic drugs, it is really a moderate evidence at weak. We don't use prophylactic amiodarone unless the patient develops fibrillation intraoperatively, then we put them on amio infusion. So to conclude, there are limitations with these protocols. There is clearly a common clinically important outcome yet to be defined. People commonly use, they are defined, but they are not studied well. So people compare pre versus post in a retrospective fashion and report their outcome just like we reported in the past. But there is no prospective trials. Is there a need for prospective trials to do that? No, I don't think so. ERATS is a good clinical practice. You don't need to have a prospective randomized clinical trial to show this is better than that. You may want to try prospective studies to compare one technique versus another, but there is no real need to study ERAS versus non-ERAS, because ERAS is you are practicing clinically best practice. Strong recommendations in spite of low evidence for many of the things we do. As I told you, there are not many studies to show ketamine works or dexmedetomidine works or block works or low tidal volume. There is a low evidence for many things, but we have strong recommendations that has to equalize at some point as we practice more. Some recommendations based on ERAS in other specialties like a colorectal or abdominal, some evidence comes up, they also practice in thoracic. So that is a kind of overlap. Compliance, as I mentioned, the low complexity of protocol. If you want to form a protocol, you want to make it as low complex as possible so that people will follow, and the compliance level is high. If the compliance level is high, you can have an improved outcome. And challenge to historical habits is always challenging. You tell a surgeon who keeps the chest tube for 3 days, it's hard to argue with them. But a surgeon who is motivated to join you, you collaborate with them and show the other surgeons that this works better than that. That's the best thing to do. So that's what we did. One of the surgeons did not agree for cardiac surgery ERAS. We excluded him from the protocol, and we presented other surgeons' outcome in a big meeting, and then they have to come inside the protocol. That's the way to do it. There are 1,000 studies on pain management, but no solid conclusions. So you will practice, we can easily say regional analgesia is the key for thoracic surgery. What kind of regional anesthesia you want to do, depending on your experience and what you do routinely. So that's where I will conclude. And, at some point we will discuss these things in a question and answer session. Thank you for the invitation.
Thank you, Kathir.
Thank you, Kathir sir. That was excellent talk and very informative, I should say. His talk on ERAS and DLT or bronchial blockers was very enlightening. And sir, I have a case scenario for you, which we just happened to encounter a week before. I was been called for some help in another OT wherein lobectomy was going on. And there were lot many adhesions. Double lumen tube was put, and this was very obese patient, nearly 100 kgs. And lateral position was been given. And there was, by accident, the PA was opened. And there was a lot of blood loss was happening at that time. So they were trying to clamp the PA. And at that time, the lung was not getting collapsed properly. So we had to just put down the lungs. Both the lungs were put down, and we could not ventilate single lung, which was required. The upper lung was not getting collapsed. But what was happening was that lung was getting ventilated while the other lung was getting collapsed. So when we had put the double lumen tube, I mean, my colleagues, when they had put the double lumen tube, it was okay. But I think when the position was being changed or something, in that it changed the position, the double lumen tube was displaced, and then this scenario happened. So when I rushed there for some help, it was actually that the patient was desaturating up to 70, 60, even up to 60, and we had collapsed both the lungs. We had disconnected actually, and we were just giving oxygen for some time. So, and when the saturation was coming down, we used to do hand ventilation and ventilate both the lungs. We used it as single lumen tube. So in this case, would bronchial blocker would have helped better in a better way, or what would you do in such case? Because this was ongoing surgery, the PA was opened, we couldn't reposition him and reposition the DLT also. So how would you manage this scenario?
So this happens, so the disasters in the thoracic room are very common. So your PA started bleeding in the field. This is a thoracotomy or a VATS or converted to thoracotomy. I assume
thoracotomy. It was thoracotomy only.
It was thoracotomy to start with. And was there, when you tried to do any bronchoscopy at all?
No, they had put the DLT by clinical method only, without using bronchoscope.
Okay, so I think, do you have bronchoscope at your center?
Yes, we have. We have.
I mean, I will. It's almost like a standard of practice to use fiber optic bronchoscope to place lung isolation devices, whether it is a double lumen tube or bronchial blocker. So you have to do that during induction of anesthesia. You also have to do after positioning the patient. And then, it's not a bad idea to recheck it again and again during the case, especially when you are isolating. I think the displacements are common. So you have to periodically check. So this complication should be prevented. Once it happens, it's hard to treat. So because I assume you have blood in the airway, if then the fiber optic bronchoscope become very difficult, then I think the best thing to do is what you did in that scenario, because you have to give massive transfusion, you have to manage other things. The best thing to do is bring the tube to the tracheal position and, basically ventilate both lungs manually, and then, manage the patient till they clamp the pulmonary artery. Trying to focus on replacing this tube into the left side or right side, whatever it is, and then leaving the other aspects of patient management can be dangerous. So because you are focused on your bronchoscope, not looking at the monitor, not looking at anything else can be dangerous. So the best thing to do is what you did ultimately, in my view. I think the oxygen insufflation, apneic oxygenation can help to some extent because the patient is pre-oxygenated to some extent. You gave 100% oxygen. People talk about FiO2. I always do 100% because scenario like this, you have more oxygen storage, and there is no evidence to suggest if you give low oxygen, better outcomes or anything. There's no solid evidence. So I always give 100% oxygen when I do one lung ventilation. People may disagree, but that's me. But I think in such a scenario, as I told you, you should have prevented this complication.
Exactly.
By checking this before. But once it happened, I think what you did is very, very reasonable to do. Heroic measure. If you have a lot of help in the room, if you have 10 people in the room, okay, bring a bronchoscope. You can even place a bronchial. You can pull the double lumen. You can reposition the double lumen tube. People also position bronchial blocker through the double lumen tube.
To the single lumen, which we made single. Yeah.
Right. Oh, okay. So you converted double to a single lumen under lateral position?
Yeah, under lateral position.
Wow, that's probably I will not do. Considering the patient is in lateral position,
we had
and you
to
may
pull
lose
it up. Yeah.
You may lose the airway. That may be more dangerous. Instead, I will just pull the double lumen tube into tracheal position.
That only we do. No, we didn't convert to single. We pulled it up to bring it to tracheal lumen.
Yeah, makes sense. So totally makes sense. You withdraw the double lumen into the tracheal position and used it as a single lumen tube. Whenever possible, you ventilate. If you have more help, you can put a bronchial blocker through that, or you can
that is one thing which we can do is in between the surgery only we can place a bronchial blocker with the help of bronchoscope. Fine. And sir, this patient we extubated on table just to make sure that no neurological compromise had happened. So patient was okay, extubated on table, and he's doing fine.
That's great. I mean, usually patients have a good tolerance for hypoxemia for extended period of time. If you can fix within 5 minutes, if you can maintain 70-80% saturation during that time, patients do fine.
Thank you, sir. Thank you for enlightening us with your experience. And Shiv, sir, can we proceed further?
Can you see this tube? Yes. This is by Ambu.
Yes.
Yeah, it comes with its own fiber optic scope. So we have actually replaced all our double lumen tubes with this one.
Okay.
So you don't actually have to use a bronchoscope and things. You can monitor it throughout.
Okay.
So this is the Viva side tube, I guess.
Yes, that is the Viva side here by Ambu. Yeah.
Even the insertion is very easy. If you just don't need anything. You just need to push the tube and you'll know where exactly it is going.
Nice. So there are so many recent developments like that one. You can also have, nowadays there's a tube which can fit into right and left both. So you just insert a tube, it just fits into, you don't need to differentiate between.
But bifeed thing, no sir? That easy blocker it is called. Bifeed.
No,
bifeed.
Not double lumen tube. I was talking about, usually we don't have double lumen tube, universal double lumen tube. But there is one in our institution we are trying, and it works great actually, even for right-sided. If you put it in right side, it doesn't obstruct, doesn't do anything. It has a configuration like openings right there above the right bronchus without displacement. It's really nice. But so there is more in development, but with bronchial blockers coming into clinical practice, as I told you, it's 50-50 in my clinical practice, at least.
So should we take next talk? Shiv sir?
Yeah, go on. Yeah.
Yes. Coming up, thank you, Kathir sir. That was great discussion and it was very helpful for us. Now let us come to our next topic, and the topic is chest wall blocks in cardiac for non-cardiac patients as well as cardiac patients. And this will be presented to us by Dr. Akhilesh Pahade. He is assistant professor at SRMS Institute of Medical Sciences, Bareilly. He has many achievements and he has many publications, around 40 of them. He is guest editor and editorial board member of BMC Anesthesiology. He is a reviewer and faculty speaker of many journals and has attended many webinars and conferences. So over to you, Dr. Akhilesh Pahade, for chest wall blocks in cardiac surgery.
Yes. Thank you, Amarja ma'am. After that wonderful talk on ERAS and lung isolation methods by Kathir sir, let me move on to a topic which contributes to the ERAS protocol. I am Dr. Akhilesh Pahade, and I shall be delivering the next talk on chest wall blocks in cardiac surgery. Now, if we go through the evolution of pain management in cardiothoracic surgery, we'll find that in the initial phase of the cardiac surgery during the 1980s, there was a practice of high-dose opioid-based anesthesia regimes that resulted into significantly longer post-operative mechanical ventilation and ICU stay. With the advent of newer, shorter-acting opioids, but potent opioids, this shortened the post-operative ventilation time. And opioids over the time have gone through a phase of decline, primarily due to maybe financial considerations, opioid-related side effects, and probably in an attempt to curb the opioid pandemic. All of these has led to the multimodal analgesia approach. Nerve blocks have become essential components, even though a lot of centers are still using the central neuraxial blockade techniques, as Sir had mentioned in his talk, and it's perfectly fine because there have been n number of studies which mention the success of the central neuraxial blockade techniques. But still, the people probably are apprehensive owing to the coagulopathy and the patients being on antiplatelet drugs, and are very apprehensive of using central neuraxial blockade methods in the cardiac surgery. So what are the advantages of regional anesthesia? The advantages of regional anesthesia include primarily the reduction of sympathetic response, which is essential in a cardiac patient, fast tracking and early extubation, early mobilization physiotherapy, and to minimize the respiratory complications, reduce the ICU and hospital stay, reducing the cost of treatment, and curbing the opioid epidemic. So before we move on to the individual blocks, let's know a bit of the anatomy. The thoracic chest wall is primarily supplied by the thoracic intercostal nerves T2 to T6, and each spinal nerve gives rise, when it exits the intervertebral foramen, it divides into a dorsal rami and a ventral rami. The dorsal ramus gives rise to the posterior cutaneous branch and also supplies the muscles, bones, and joints of the back. The ventral rami innervates the lateral and the anterior part of the chest. When it crosses the mid-axillary line, it gives rise to the lateral cutaneous branch. It terminates by giving out the anterior cutaneous branch, and apart from this, it gives muscular branches to the transversus thoracis muscle, innermost intercostal muscle, external oblique, external intercostal, and intercostal muscles. Now, these chest wall blocks can be categorized into three: blocks involving the anterolateral chest wall, that is the PEX1, PEX2, and the SAP block. The blocks involving anteromedial chest wall, that is the pectointercostal block and the transversus thoracis plane block. And for posterior chest wall, we have thoracic paravertebral block and the erector spiny plane block. We'll be discussing each of them. Moving on to the anterolateral chest wall. Continuing with the anatomy, in this figure, the one on the left side, the encircled portion that you see is the anterolateral chest wall. You can see the bulkier pectoralis major right here. Underneath it is the slender pectoralis minor. The drug, when it's deposited between them, it's the PEX1 block. Then is followed by the sheet-like serratus anterior. And the drug, when deposited between minor and serratus anterior, is the PEX2 block. And towards the end of the, at the junction of the lateral wall and the posterior wall, there is the latissimus dorsi and the serratus anterior. And when the drug gets sandwiched between them, it gives rise to the SAB block. Now, going on to the distribution of these blocks, if you see that the PEX block together, which they are generally given as, they they block the upper half of the anterolateral wall and the axilla. And probably that was the reason that they were initially described for mastectomies and axillary clearance. SAB block covers the anterolateral wall extending from T2 to T9. The point to be noted is that they do not supply the medial part. And so they won't be sufficient when the medial part is involved, that is, if there's a midline sternotomy. As a result of which, what has happened is that the indications for these blocks is mainly restricted to surgeries such as thoracotomy, VATS, pacemaker incision, etc. And the complications associated are pneumothorax, vascular injury, and winging of scapula. Going on to the block technique, the PEX1 block, the patient should be supine and the arm slightly abducted. Using the linear probe, we place the probe inferior to the clavicle above the third rib. I personally prefer to rotate the probe so that it is slightly oblique to the spine and medial to the coracoid process. In this way, it will be in a position that we can administer the PEX2 block as well. A 22 gauge block needle or the toy needle may be used and inserted via this plane. And 10 ml of local anesthetic is deposited to block the medial and pectoral nerves. Going on to the sonoanatomy, when you place the probe, the structures that need to be identified are, first of all, you place a probe on the third rib. You identify the axillary artery and the axillary vein. And then you see that there are two bulky muscles. One is the pectoralis major, the bigger one. Underneath it is the pectoralis minor. Now, in order to identify the plane, what we need to identify is the pectoral branch of thoracoacromial artery. It serves as a landmark. And the problem with this artery is that it lies in the plane exactly between these two muscles. And even if it acts as a landmark, it would actually poses a danger of either getting injured, resulting into a hematoma, or being a victim of intravascular injection from this side. The next is the PEX2 block. In this, generally the PEX2 and the PEX1 are given together. This is primarily because the PEX1 covers the area supplied by lateral medial pectoral nerve. And this block helps in covering the areas from T2 to T6, thereby covering a larger segment of the anterior lateral chest wall. The probe may be moved slightly downwards on the fourth rib, and the block has to be and 10 ml of PEX for PEX1 and 15 ml of local anesthetic for PEX2 will give you the desired results. If you see the sonoanatomy, you will see a pectoralis major, pectoralis minor, and underneath them is the serratus anterior. And this is the fourth rib. And so you have to deposit the drugs in two planes. One is this, that is the PEX1, and this one, that is the PEX2. Now these blocks, PEX1 and PEX2, can also be given in condition if you do not have an ultrasound. They are landmark based, and they can also be given as landmark based approach. The patient lies supine with the arm slightly abducted. The landmark is the mid-clavicular line and the junction at which it crosses the third rib. We breach the skin, go perpendicularly, hit the third rib. This will give us an idea about the skin to rib distance so that we don't move any further and cause complications like pneumothorax. Now withdraw your needle up to the skin and slowly advance. The first pop is that of the prepectoral fascia, and the second pop will be achieved when you enter the facial plane. Deposit 10 ml of local anesthetic there for the PEX1 block, and now advance it further to hit the rib and just withdraw a couple of millimeters and deposit 20 mils of local anesthetic to achieve the PEX2 block. Next is the serratus anterior block. The utility of SAB block in cardiothoracic surgeries is more or less limited to thoracotomies, VAT surgeries, thoracoscopies, and management of rib fractures. Once you have achieved the view for the PEX block, you just need to move downwards and laterally or posteriorly, you can say, to reach the fifth rib in the mid-axillary line. And what you see is a latissimus dorsi. Underneath the latissimus dorsi is the serratus anterior. And you can deposit the drug either between these two muscles or under the belly of serratus anterior. The thoracodorsal artery, like the thoracoacromial artery that we had encountered in PEX block, again serves as a landmark and poses the same threat as explained before. Again, this block can also be given by a landmark or peripheral nerve stimulator based approach. The patient lies supine with arm abducted. In the mid-axillary line, fifth rib junction, just go perpendicular to the skin, hit the rib, withdraw 1 to 2 millimeters, and deposit the drug. If you are using a PNS, just see the contraction of serratus anterior. Next, we move on to the blocks of anteromedial chest wall. There are two blocks, the transversus thoracis plane block and the pecto-intercostal facial plane block. Going on to the anatomy, the encircled portion is the area of our interest. And if we magnify it, we'll see that this is the intercostal nerve, which is traveling on the transversus thoracis muscle. It gives the anterior cutaneous branch, which traverses through the internal intercostal, following which is the pectoralis major, and innervates the skin on the anteromedial chest wall. Now, the drug can be deposited either between the pex major and the internal intercostal, or between internal intercostal or transversus thoracis. If we see the distribution, we had seen this figure previously also. And now if we have to cover the entire hemithorax, the anterior segment, anterior part, then we have to either use this anteromedial blocks along with the SAP or PEX block, or use some other block which we'll be discussing further. So the indications for this block, or where this block will be helpful, will be midline sternotomy, thymectomy, mediastinoscopy for pericardial window, or as an adjunct to the PEX block in breast surgery. The complications include the pneumothorax or the vascular injury, local anesthetic toxicity, and intravascular injection. The patient lies supine. The probe stays parallel on the third and fourth rib. And at a depth of 1 to 3 centimeters, we will see this picture. That is, we can see the pectoralis major lying on top of the ribs. Underneath it is the intercostal muscle. And further below is the transversus thoracic muscle. Now you can deposit the drug between these two muscles in the plane between them, or between the intercostal and the transversus thoracic muscle. The problem with this block, that is the transversus thoracic plane block, is that transversus thoracic muscle is a relatively thin muscle. Many people will encounter difficulty in visualizing this muscle. And secondly, if you go further deep, there next to this muscle is probably the pleura, which you will, again, there's a probability that if you go deep, you might just rupture the pleura. So it is often considered safe that if the drug is deposited between pectoralis major and the intercostal muscle, it will provide the desired results. Next, we move on to the blocks of the posterior chest wall. A number of blocks have been described. However, we will be mainly focusing on the thoracic paravertebral block and the erector spinae plane block. From the medial anteromedial end, we moved on to the posterior end because this is the seat of the paravertebral space and the erector spinae muscle. Now, this paravertebral space is a space where the spinal nerve comes out and bifurcates into the anterior rami, ventral rami, and the dorsal rami. And this is a wedge-shaped space, and it is bounded by the bodies of thoracic vertebra medially, parietal pleura anteriorly, and thoracic transverse processes and head and neck of the rib posteriorly. Another structure that is of importance or interest to us is this muscle. That is the erector spinae group of muscles, which comprises of three muscles, three band-like muscles, the iliocostalis, the longissimus, and the spinalis muscles. They run bilaterally from the skull to the pelvis and sacral region, and from the spinous to the transverse processes, extending to the ribs. And thus they create kind of a plane that permits extensive craniocaudal spread of the local anesthetic to cover multiple dermatomes by a single injection. The block should be performed as close to the costovertebral foramen as the LA seeps through the costovertebral foramen and effectively acts like a paravertebral block. Too medial an injection can lead to a late onset and retrolaminar block, and too lateral will lead to poor penetration. Now, the indications for paravertebral block or the erector spinae block are kind of, you can do all the surgeries in these two blocks. The sternotomies, the thoracotomies, the VATs, minimally invasive cardiac surgeries, the esophagectomies, and even the non-cardiac surgeries like liver resections or open cholecystectomies can be done with these blocks if given at the desired level. The complication again are pneumothorax and sympathetic block. The sympathetic block mainly because the ventral and the dorsal rami, they communicate with the sympathetic chain. Now for the paravertebral block, we place the ultrasound probe in a caudal cranial orientation about 5 centimeters from the midline at the desired level. At this point, we identify the ribs and pleura, and we maneuver the probe medially to look for the transition of ribs to the transverse processes marked by a change in shape and a slight step up of the bony image. We rotate the probe slightly anti-clockwise while fixing the cranial end of the probe. The image acquired will have the transverse process on the top, that is superiorly, and image of the rib inferiorly. And this is the wedge-shaped structure, which can be seen on this image as well. And the local is deposited at this point. Again, thoracic paravertebral blocks can be administered by a landmark method also. The entry point is 2.5 to 3 centimeters lateral to the corresponding spine. And after local infiltration, the block needle is advanced perpendicularly to the skin till it makes contact with the transverse process of the corresponding vertebra. LOR syringe is then attached and the needle is directed inferiolaterally while advancing it by a maximum of 10 to 15 millimeters. As the needle passes through the costotransverse ligament, a pop is felt, and that is where you deposit your drug. PNS can also be used while visualizing the twitch of the intercostal muscle. This is the sonoanatomy of erector spinae plane block, where if you place your probe at the level of T5 or above, you will see this kind of a sonoanatomy where there are three muscles, trapezius, the rhomboid, and the erector spinae. And you have to deposit the drug under the erector spinae muscle. Also, the erectospiny plane block can be given by landmark approach. The landmarks are the same as the paravertebral block. The only thing is once you hit the transverse process, you just have to deposit the drug there after withdrawing your needle by 2 to 3 millimeters. So I'm coming to the end of my talk. And the take-home message from my side is, 1, perform PEX 2 before PEX 1 if you are performing 1. Count the ribs. PEX 1 lies on rib 2nd and 3rd, PEX 2 on rib 3rd and 4th, and SAP block on rib 4th and 5th. Hydrodissect prior to injecting the LA for greater success. Always look before you leap and be beware of the blood vessels as facial planes have a number of them. Beware of the pleura, especially in case of anteromedial blocks and paravertebral blocks. And as Sir said, follow what you're best at or what you're comfortable with. There is no rule that you have to follow a certain technique because someone else is following it. Follow what you practice and what is giving you the desired results. This chart I had taken from an article published in Anesthesia and Analgesia. It was from the Cleveland Clinic, and as you can say that almost across the board, you can see the ESP or erectospiny plane block doing the job for you. So just take your pick. If you're comfortable with central erectional block, go with that, or with paravertebral, or with erectospiny, whatever suits you. Thank you.
Thank you, Akhilesh.
Thank you, Dr. Akhilesh. And I have heard you for the first time, and I must say that it was crisp, to the point, and very nice presentation. And your slides too were very to the point. And now I would just want to ask you one question. Do you put epidural catheter in any of these blocks, like for erectospiny plane blocks? Or any?
Yes, ma'am. Yes, ma'am. It's you can put an epidural catheter, and a continuous method can be followed for paravertebral or erectospiny plane blocks. Once you do the hydrodissection, you can easily place the catheter inside.
Yes. So have you any time noticed a failure of these blocks?
Yes, failure is possible, definitely possible, ma'am, because the patient is often moved, or like it happened with the DLT as well. There's always a possibility that the catheter can get malpositioned and get kinged, or the drug may not reach the desired site. So there's always a possibility that the block might fail despite you taking full efforts in this.
Okay. And then you go to your IV regimen, whatever.
Yeah.
Yes. Now my question is for Kathir sir. Like, are Americans also fond of these blocks for cardiac and non-cardiac surgeries?
Yeah, so there is an epidemic of blocks.
That is why.
So, okay, so since you asked America, it's a pandemic of blocks. So, it's really a common practice. Let me may add one. When you showed that anesthesia analgesia article on sternotomy, ESP and PEC blocks, I think Stanford University and even our university combined and did we didn't report combined results, but we did a study on ESP blocks. ESP catheter was put in preoperatively, and then we gave placebo versus local anesthetic, and then we followed the catheter for 3 days. And then taken out at the end of 3 days in sternotomy patients undergoing cardiac surgery. And literally there is no difference in pain scores, opioid consumption, or outcomes or anything. So I will be cautious when you read the review articles and, so without solid evidence. I think they are going to publish their results from Stanford. Theirs is more prospective, randomized than ours. So from our practice, I will tell you, our pain service, we have a pain service which does the blocks in the morning so that you focus on other things like cardiac induction and stuff like that. So pain service come at 6 o'clock, they put the block in, and you're happy to see the patients with block sitting there. So they started doing ESP blocks for these patients, and previously they used to do paravertebral blocks, and then the surgeons, we don't follow the patients. We follow the patients maybe at a point of time. You go and see 24 hours later, but the surgeons see these patients continuously. So they clearly identified a difference. Hey, you guys are doing anything different from pain block point of view? All our patients are in severe pain. So they identified immediately that the ESP blocks did not work. So we converted back to paravertebral blocks, and then, restored back to normal. So I will say still, neuraxial blocks, are the best. You can supplement your blocks with chest wall blocks and other things, but nothing can take over a properly working epidural in thoracic surgery. Then or intrathecal morphine works great for 24 hours for sternotomy, and then you can manage the remaining period with other drugs. So I have mixed opinion about this blocks, but I'm sure there is more learning experience. It may get better.
Okay. Now I have a comment for Shiv sir. Shiv sir, today you asked on Facebook, I just read it because there was no time to reply, that is our group still, should we continue, or is it still useful for you?
Don't worry about that.
No, listen, I have an answer for that. Way ahead of time, before 3, 4, 5 years, we started about these blocks.
Yeah.
Yes, I think we were the first pioneers in celebrating these blocks, or making them so reach everyone. Yes, and teaching them and conducting webinars, seminars, hands-on. Yes, and now it is protocolized everywhere.
Yeah.
So that was my answer for your question. And now can we proceed to third talk?
Let me come to the. There's a lot of, actually, if you are on Twitter, and now Astra meeting is going on in Paris. There's a lot of debate about whether ESP works or not. And I can tell you with great confidence that even before it was published, I was one of the persons who actually started using the erector spinae block. And I still have the videos of them, because I videoed this. I have videos of all my blocks, and I did it for spinal surgeries. My reason for was it to actually find a technique for spinal surgeries, and they worked beautifully. Okay, and the reason for is very simple. We know that the spinal nerves come out, they divide into anterior, ventral, and dorsal branch. And you need to block the dorsal branch for spinal surgeries. And that's what get blocked for in erector spinae. So it is going to work. But I'll tell you why I did not publish it in a minute. So if you look at it, people have been publishing erector spinae for everything. They have gone to even, saying that, oh, we can do it for hips and things like that. I think it's a nonsense. The reason being that if you look at the thoracic level, if you're in the right plane, I can actually show you. If people actually send me a video of erector spinae block, I can actually tell you the minute it is going to work or not. Right? I have seen people saying that, oh yes, this is there. No, it's not. It's very easy to actually be in the fibers of the erector spinae, spinalis, and you will see a nice spread along the muscle. And that's an intramuscular block, okay? And you're not in the right plane. And it's not going to work, one. And if it's not deposited in the right plane, it is not going to diffuse. It takes at least 20 to 30 minutes if you're in the right plane to actually block the anterior division. it is supposed to actually go through the costotransverse ligament, foramen into the anterior. And that probably might happen if you're in the right place, then it will work. But you have seen, I mean, you, Akhilesh, you actually showed nice diagrams with these things. Somehow, I don't know why, they don't seem to reach, the analgesia doesn't seem to reach till the sternum. Okay. And this I actually noticed it when I started actually doing the breast list, because one of the main indication where erector spinal block were being used was for the breast surgery. And I don't paralyze any of my patients. Okay, I use blocks, I use operatory anesthesia. They would be fine as long as surgeons were operating on the lateral side, anterolateral side. As soon as the incision actually started coming to the medial side, suddenly there would be a clear response, heart rate going, blood, and the patient's respiratory rate going. There was a response inside. Okay, and all this terminologies of pectoral-intercostal block, and they can actually give number of names to them. Okay, it's such a simple block. Okay, I'm not talking about doing a sternotomy here, but you want to block anything there, all you need to do is go 3 centimeters lateral to the sternum. Okay, go under your origin of pectoral as major, okay, and just infiltrate local anesthetic between the muscle and the rib. Even if you do not actually have ultrasound, right, hit the rib, come out, and just along the sternum, inject local anesthetic, it will work beautifully. Okay. Same thing with the erector spinal block. It is more likely to actually work if you actually do it blindly. Hit the transverse process and inject. And you do the ultrasound, you will see a lot. People do it with ultrasound and trying to actually get it. And talking about, you actually asked about the catheters, epidural, the erector spinal. Erector spinal catheters will fail magnificently. Okay. The reason being, most of the time they are not actually properly placed. Okay. And the spine moves. Okay, go flex. Right. Patient is actually doing that, and the catheter actually moves out. This is same thing which it is very easy to actually move on. I have seen that happening in patients. We put these catheters for rib fractures. Okay, they would come out. They are very difficult to secure. So if you're doing those catheters, make sure that you lube them and use a tissue glue to actually keep them in place. Otherwise, they will actually move easily, because patients are lying on their back, right? They do not lie still. Okay, they wriggle, and with the wriggle, it will actually move. So the catheters, need to actually fix them properly. Okay. These are not difficult blocks to do. Okay, pectoral blocks for the chest are only required if you are actually going to operate on the muscles. You do not, PEC 1 and PEC 2 actually have got no place. Serratus anterior plane block, again, works better if you deposit local anesthetic under the serratus anterior plane muscle, okay, rather than over the muscle. And this has been again proven again that they better work if you are actually, and they need to be a little bit more lateral than actually going on medially. Be lateral, where you can actually see the latissimus dorsi come at that level and inject under the serratus anterior. Again, this block can also be again given without actually requiring ultrasound. Even in the very obese, you go on the side, you can feel the ribs. There aren't too much tissues there. Okay, you can feel it very, very easily. You just hit the rib, okay, and angle the thing. It's not like that. You have to be at level of the third rib or fourth rib. You just feel it, go above, go below, and inject just over the rib under the serratus anterior, and it works. These are very simple blocks, and they work really well. I think that's it.
Thank you, sir. Thank you so much. Can we move to our third?
Yep, absolutely.
Yes.
Absolutely.
So our third talk is by Dr. Minati Choudhury. She is professor at AIIMS, Delhi. She has several awards to her credit. She is editorial board member, and she has more than 200 publications. And today she'll be talking on post cardiac transplant patient coming for abdominal surgery. Over to you, Minati madam.
Thank you, Dr. Amarjia. Thank you, Sid sir and Dr. Amarja again for giving me the opportunity. And after these two enlightening topics, I'm going to discuss about the patients whose number is very less. And they are the post-cardiac transplant patients for coming for the abdominal surgery. I have nothing to disclose. And if you can see the incidence of the heart transplant across the world, it varies around 5,000 to 10,000. But now it is gradually increasing. And because the number is increasing and there is development of the technique, development of the surgical technique, and new drugs are coming, so there is increasing survival. And more of these patients are coming for the non-cardiac surgery, again for the abdominal surgery, which is again related to the disease itself or due to some other disease. For the abdominal surgery, again, they can come as an elective basis or the emergency basis. But the incidence, as you see in the world literature, it is quite high, that is 36%. And they can come for this surgery and from 2 hours post-operative period to more than 10 years. In between the span, they can come at any point of time. And as this transplanted heart are different, so there is unique anesthetic implication of a transplanted heart. And so the incidence of surgical complication is also a bit high when you are seeing the non-transplanted heart. So after the talk, we'll discuss regarding key patients. One is post-transplant, posted for emergency appendectomy. One is day 2 post-transplant for the resection anastomosis of the due to mesenteric vascular thrombosis. And case 3 is again 6-year post-transplant for the exploratory laparotomy. So why you want to go for the abdominal condition? What are the abdominal conditions for which the patient needs surgery? They can be inflammatory, it can be perforative. For the inflammatory simple esophagitis, they can go for a diagnostic esophagoscopy, and there may be ulcer, infection, perforation, ischemia of the gut. There may be tumor, there may be adhesion or hernia. So for all these variety of reasons, the patient has to undergo a abdominal surgery. But however, the common one are the exploratory laparotomy, cholecystectomy, and appendectomy. These three are often happen. And also for the surgery for the pancreatitis. So because this set of patients are different, so what one should know? So transplanted heart is unique, and the anatomy is a bit different than the normal heart. Physiology is again different because heart is denervated. And the pharmacological responses is again very integrated because the patient are receiving immunosuppressive agents. And these agents have reaction among itself. They had lot of side effects. Also, there is complex drug interaction among the anesthesiology, among the anesthetic drugs and the immunosuppressant and other things. So the anatomical problem, this basically occurs depend upon the surgical approach. So there are usually two methods of the transplant. One is bilateral technique, one is bicaval technique. In the bilateral technique, what happens? The posterior part of the recipient heart and posterior part of the left atrium, recipient right atrium, posterior part of the left atrium along with the pulmonary veins, and the posterior part of the intraatrial septum is kept intact. So the once you anastomose with the donor heart to the recipient heart, there is increased apival dysfunction in these cases. There is increased incidence of arrhythmia, and many of these patients they need the permanent pacemaker implantation. This method, however, practiced by very less people. So another is that is the bilateral approach. In the bicaval approach, in the bicaval approach, what happens? The posterior part of the right atrium of the recipient only kept intact, and vena cava to vena cava, again aorta to aorta, and the pulmonary vasculature is anastomos. So in this case, there is a near preservation of the arterial geometry. So the mean pulmonary artery pressure is again usually remain in the low side, and there is less incidence of valvular regurgitation, arterial arrhythmia, and less incidence of the permanent pacemaker requirement. So what happens to the physiology of the transplanted heart? This is essential when we are going to give anesthesia. There is change in arterial geometry, as I said, and because the part of recipient atrium is also there, there is increase in the arterial size. There is increase in the right atrium and left atrial end systolic volume as well as the end diastolic volume. And there is increase in the right atrial pressure at the same time, but do not always consider it and if there is any RB dysfunction. There is some grade of functional atrioventricular valve regurgitation, and in which tricuspid valve is more common. There may be some mitral valve regurgitation is also there. So the transplanted heart, as you know, is a denervated organ. So lot of physiological changes also happen. So the atrium is there, the recipient atrium is there, but however, the impulse that does not cross the suture line. Even if the transplanted heart is a denervated organ, the intrinsic cardiac mechanisms, they all remain preserved. And the resting heart rate in these cases, they vary between 90 to 110 beats per minute. So there is higher minimum heart rate. But however, the heart rate variability to the different response is usually blunted. So normally what happens in the physiological stress, pain and hypovolemia, if you don't have much monitor and patient is under GA, you can name any of the response from the tachycardia response of the patient. But however, in the transplanted heart, this response is also blunted. Again, as you can see, there are two P waves in the ECG. You should not consider this as abnormal. One P wave is a rise from the right recipient heart and one P wave from the donor's heart. But however, there is lack of functional efferent systemic vasomotor input. So these are the patients, they have no response to many of the physiological reactions. So again, the incidence of dysarrhythmia is very high, that is around 50%. This is mainly because these patients have unopposed sympathetic tone and decreased parasympathetic tone. There is increased sensitivity to circulatory catecholamine. So usually 30% of the patient have right bundle branch block, and that is usually first degree. Arterial premature beats occur in a substantial number of patients, that is 76% of cases. And arterial flutter and arterial fibrillation, usually they start later. The incidence is 18%. And the start of these things because the heart started re-innervating. So this is the cause of arterial fibrillation and arterial flutter. As the days pass away, the incidence is more. And many of these patients again have ectopic ventricular beats, and these are usually non-dangerous and they are not related to rejection. But if there is a fatal ventricular fibrillation, there is a lot of hemodynamic instability, then one has to suspect regarding rejection. Then CPM requirement, that is again in the bilateral anastomosis patient, the permanent pacemaker requirement is much more than when the patient has undergone a bicaval anastomosis. That means one has to look for the pacemaker function before the patient is going for the surgery. And again, there is a lot of physiological changes. These are the patients who have preserved functioning mechanism. So they have some normal response to preload. So that these are the patients who depend upon the venous return further to maintain the cardiac output. And the heart rate response usually increase during for the circulatory catecholamine. But however, one has to be careful because these are the patients, they have attenuated orthostatic hypotension. They have a greater left ventricular mass, so the oxygen demand is much more during the stress. So there is lower maximal heart rate and lower cardiac index, but the oxygen requirement is much more. And so these are the patients, they are more prone for the ischemia. The systolic function in these cases, they are usually normal, but the diastolic compliance and the relaxation is abnormal. So next is, these are the heart rate. They are unresponsive to any changes in the systemic blood pressure. This is because there is absence of the baroreceptor reflex. And they are also unresponsive to the carotid massage, pulsar maneuver, any respiratory changes. You cannot also know whether your patient is light or your patient is, you are intubating, patient is not in the right plane, or patient needs some more analgesic. because there is no difference in the heart rate during tracheal intubation. Same thing when the volume status is also less, you cannot know this thing from the heart rate. Same also for the surgical plane. And there is less of heart rate response to the postural changes again. And one more important thing is in these cases, there is lack of angina symptom prior to myocardial ischemia. So that means even if ischemia happens, it is silent, and if one is not carefully and vigilant on the monitoring, that they cannot know there is silent ischemia is happening to this patient. Then the incidence of the vasovagal episode and the cardiac arrest is very high in this case in the neostigmine administration. So usually neostigmine is avoided in many of the scenarios. Interesting is coronary autoregulation is intact. So coronary blood flow is intact unless there is coronary vasculopathy in these cases. So if the patient is coming immediate post-transplant for any surgery, there is some grade of LV dysfunction. But this LV dysfunction is due to anoxic injury during graft transfer, acute withdrawal of the sympathetic support, or afterload mismatch. But these are the things which are normalized within days or months. So if the patient come later on, you need not to be worried regarding the left ventricular dysfunction. In the initial stage, for 1 month, there is increase in pulmonary artery pressure and PCWP, for which we give pulmonary artery pressure reducing agent, and this usually stay for 1 month and gradually stable by 1 year. So you need not to worry if the patient is coming after 1 year. And there is increase in systemic vascular resistance, there increase on normal cardiac output, because the blood volume is increased by 15% due to increase in the venous return and increase in the preload. So what are the pre-operative concern in these cases? Because all these cases, they are on immunosuppression and their interaction with the commonly drug in the perioperative period is a major concern. The commonly used drugs in these cases, usually the combination of a steroid and calcineurin inhibitor, they are cyclosporin tacrolimus, or antiproliferative agent like mycophenolate maleate or azathioprine. Initially, most of the patient is to get a combination of the cyclosporin azathioprine or tacrolimus azathioprine or cyclosporin mycophenolate. But nowadays, we are giving more of tacrolimus and mycophenolate. So this combination have less of side effect and they are more compatibility with the patient. So again, one has to know what this immunosuppressant has done with the whatever drug we are giving. We are giving the anesthetic agent, antibiotic, antimicrobial, antifungal, and antiretroviral agent also in many of the patients. So what these drugs usually do? So you can see the benzodiazepine concentration is increased with both cyclosporin and tacrolimus. Again, most of the antibiotics specially used in these cases, they are cotrimoxazole, metronidazole, and then rifampin and antifungal agent also. They all have increased in the level. Antiretroviral, again, the drug level is increased in the blood. So one has to monitor the concentration of the both the cyclosporin and tacrolimus in these cases. Secondly, in the cardiovascular drugs, among the cardiovascular drugs commonly used are amiodarone, lidocaine. All these drugs again increase the level of the cyclosporin and tacrolimus level. So you have to monitor both the drug concentration. Starting again very less of effect, but in the high dose again they have effect. So avoid use of these drugs in the initial period. Anticoagulant, again, there is increase in the concentration of the anticoagulant. So monitor the level of the anticoagulant agent. Hypoglycemic agent, again, increase the cyclosporin level, and both drugs used for acid peptic disease and metoclopramide, they increase both the drug level, both cyclosporin and tacrolimus. So monitor the QTC interval in these cases because the QTC interval is increased, and these are the patients who are more prone for the arrhythmia. Secondly, all these immunosuppressant agents, they have lot of side effects in the gradual course of time. Many of them have hypertension, diabetes mellitus, dyslipidemia, seizure, electrolyte imbalance, and in the extreme stage, they may have neoplasia and the pancreatitis. So one has to remember measure of the side effects to manage your patient in the preoperative period or stabilize the patient in the preoperative period. Anesthetic drugs, they also have interaction with these immunosuppressant, and sevoflurane, however, have very less or minimal effect. So mainly it is one of the drug of choice while doing all these cases. And the clearance of the cyclosporin again increased with the isoflurane anesthesia, and mostly it is avoided. Thiopental, propofol, and intermediate, they do not have any interaction with these immunosuppressant, can be used safely. Again, as I have said, the midazolam, the blood level is increased, so dose modification has to be there. Neostigmine, again important. Neostigmine, when given along with the immunosuppression, there is incidence of the bradycardia, asystole, and cardiac arrest in some set of cases. So one has to avoid and prefer Sugammadex or gradual withdrawal of the action of the muscle relaxant if at all possible. And opioid, again, the cyclosporin basically increase the analgesic effect produced by the fentanyl. It is a good thing. You need not to modify the dose so much because there is no lot of alteration of the drug effect. Local anesthetics, again, bupivacaine, ropivacaine, both can be used safely with all these 4 agents without any side effect. There is some knowledge regarding the post-transplant complication. Also, one has to know, and because these are the complications, they occur in the post-operative period also after once the abdominal surgery is over, especially if it is a major abdominal surgery. Or the patient might be suffering from all these post-transplant complications. So one has to fix all these complications before only. So first one is infection, and there is increased incidence of wound infection, especially if the patient is tacrolimus is taking. So in this case, even if there is no evidence of infection, a strict aseptic technique one has to take during any of the procedure, and you should decrease the use of indwelling catheter and remove the invasive line as early as possible. If there is associated fungal infection or any evidence of fungal infection, give CMV negative blood transfusion to this patient and add one antifungal agent as well. And one has to remember, if it is elective surgery, one has to control the infection pre-operatively for a safe post-operative period. And the period coverage of the antibiotic is a must unless it is a small procedure. Rejection, again, in the major surgical process, due to stress and all at times and alteration of the immunosuppression level at times, this rejection can occur. So one has to know what are the signs and symptoms. This can occur at any time. Patient may have unexplained weight gain, fever, dyspnea, and peripheral edema. They are the usual features of rejection that can happen in the post-operative period. If you have any suspicion during the pre-operative period, even if the patient has a biopsy 2-3 months before, a urgent endocardial biopsy is desirable to confirm if there is any rejection is there or not. Suppose there is any evidence of acute rejection, so one has to start emergency therapy with increase the dose of immunosuppressant, whatever the patient is taking. Give intravenous immunoglobulin and plasmapheresis and mechanical circulatory support if at all it is required. If the patient is coming after 1 year post-transplant, and most of the time there is start of allograft vasculopathy in 10 to 20% of the patients. And in 50% of the patients, the vasculopathy starts after 5 years. So patient comes after that may have prone to silent myocardial ischemia or myocardial infarction. So in these cases, usually these are the cases who are diagnosed by intravascular ultrasound. Suppose there is any evidence of the allograft vasculopathy and patient is somewhat symptomatic, and you know that there is some disorder in coronary, one angiography or revascularization is must before the patient is going for an elective surgery. Again, the diabetic, epilepsy and hypertension, which are common thing, one has to treat those things and stabilize the patient before an elective surgery. But however, while treating hypertension, avoid beta blocker. This is according to some of the authors because these patients, they respond very badly to the beta blocker. So good coordination between the transplant team as well as the attending anesthesiologist is essential before starting of the surgery. And an ECG has to be done to assess the graft function. And if there is any preoperative arrhythmia, any hemodynamic stability, that has to be fixed before. Because type of this patient again are with pacemaker. So one has to see the pacemaker function and all, and you have to consult with the cardiology team for the adequate functioning of the pacemaker. And then endomyocardial biopsy again has to be done to rule out any evidence of the rejection. Echocardiography to rule out the ventricular function and detection of any allograft vasculopathy. And when you suspect vasculopathy, then one can go for the coronary angiography. Some lab parameters is a must. That is, first is complete hemogram, because azathioprine, especially that decreases the bone marrow function, and anemia is very prevalent in these cases. So arrangement of blood is essential. Electrolyte is again important. So also liver and renal function test. Coagulation status, especially the level of platelet, is essential, and correct the peri of glucose level if there is any derangement. Some says biomarker like BNP, if the level is high, they have a role in detection of the allograft rejection diagnosis and the coronary vasculopathy diagnosis. When come to the pre-medication is similar as that of the non-transplant patient, but one need dose adjustment sub-drugs as well as the adjuvant is needed. Like if you are giving midazolam pre-medication, you have to adjust the dose. And you have to keep the dose of immunosuppressant the same. And at the same time, one has to monitor the alteration of the blood level of the immunosuppressant. Oral cyclosporin, and you can switch about 4 to 7 days before surgery. And the dose of azathioprine and oral and IV dose of azathioprine is exactly the same. If you want to switch over inside the OR, you can switch over the azathioprine dose to intravenous. And if the patient is on prednisolone, and the similar IV dose of the methylprednisolone can be given. But suppose the patient is not on any steroid medication, so supplemental steroid is not necessary for any race coverage in these cases. So abdominal surgery can be done by the neuroaxial block or by the general anesthesia. And there is no difference between general anesthesia and neuroaxial block if preload is maintained. But however, general is more preferred by most of the authors because nobody wants to see the instability by the neuroaxial block. Oral intubation again is better than the nasal because the patient can get infected with his or her own nasal flora when we are going for the nasal intubation. Suppose the patient is on cyclosporin, one has to be cautious because these are the cases who have gingival hyperplasia and bleeding while doing intubation, and this can give rise to aspiration, airway obstruction, and this airway obstruction again is occur more in the patients who are diabetic or lymphoproliferative disorder. One has to avoid hyperventilation because both the cyclosporin and tacrolimus, they increase the seizure threshold. So one has to be very careful. More important is again during the laryngoscopy and intubation, there is loss of sympathetic response. So you don't know how much pain you are producing. So it is better to give the adequate dose of the anesthetic and analgesic agent, or you can go for a anesthetic depth monitoring. LMA is again not contraindicated. You can go for surgery. Denervated heart again has a blunted heart rate response to inadequate anesthetic depth or anesthesia. So this monitor is important. As far as possible, avoid non-steroidal anti-inflammatory drug because there is every risk of bleeding in these cases. So there is no change in catecholamine receptor in the transplanted heart, even if it is denervated. So the transplanted heart, they basically respond to the direct acting drugs. That means dopamine is less responsive, but however, isoprenaline and dobutamine are more responsive, and they have the similar effect in both of the transplanted and normal heart. Atropine again have no effect on the transplanted heart. So if you want to give increase the heart rate, then go for isoprenaline and epinephrine to manage the bradycardia and hypotensive emergencies. So this is the chart showing the response of the denervated heart to various cardiovascular drugs. Standard monitoring one can go for as of that of ASA guidelines, and invasive monitoring like CVP and arterial line and echocardiography, it is depending upon the case. If you are doing a massive major case going for a very long time, or the patient has a ventricular dysfunction, component of ventricular dysfunction, and you think these patients are going to need inotrope in the post-operative period or suddenly deteriorate. So these are the cases you can go for invasive line and better to put a echo. Titration of anesthetic drug is essential. So maintain the adequate preload to avoid intraoperative hypotension. Rocuronium and cisatracurium is usually better. And if you have, go for Sugammadex and avoid Neostidium because it causes bradycardia and arrest. If there is any intraoperative arrhythmia happen, again beta blocker has a lot of controversy because it precipitates hypotension. But in the titrated dose, again, it doesn't cause any effect. Amiodarone, verapamil, digoxin, and adenosine are more preferred. But however, again, in adenosine, one has to be cautious because the asystole which happen in adenosine in the normal patient is for a very less period, but it can cause prolonged asystole in case of the patient who has a transplanted heart. In the postoperative period, routine care is same as that of the non-transplant recipient, including the pain analgesic agent. But one has to maintain the preload status. For this, heart rate is again is not important. You have to see the systolic blood pressure response and maintain the preload. Renal function monitoring is again important because the immunosuppression, they affect the renal function. Prevent the infection if it is there, continue the immunosuppressant and continuously measure the level. That is very, very important. So now come for our three cases. The first case is a 34-year-old. This case has come 2 years post-transplant for emergency appendectomy. So this patient was on simvastatin, tacrolimus and azathioprine. And the follow-up was done 7 days just before he came for the appendectomy. The ECG was normal, echo was normal. We didn't again did all these two. The endomyocardial biopsy, there was no evidence of rejection. However, the transplant team was informed. Routine hemogram and blood chemistry was normal for these cases. And we did get this case under GA, intermediate fentanyl, etc. And routine monitoring was done, no advanced monitoring was done. Patient received ondansetron 4 mg and dextamethasone 4 mg. And maintained with atracurium, fentanyl, and midazolam. Azathioprine and tacrolimus continue in the same dose. However, the azathioprine dose was changed to intravenous and tacrolimus sublingual. So no additional antifungal was given to this patient and no steroid because this patient was not receiving any steroid. On-table extubation was done and the post-op was uneventful. The second case was 35-year-old female. It was the day 2 post-transplant, and this patient has an acute abdomen and suspected mesenteric vascular ischemia and was posted for resection anastomosis. She was on tacrolimus, macrophenolate, sildenafil because the pH pressure was a bit high, and methyl prednisolone at a dose of 200 mg BD, meropenem and tagocid. So these drugs were continued while taking the patient, and drug status was remained the same, and drug level was again monitored. And we added voriconazole, valganciclovir, one anti-retroviral, and metrogyl to this patient. Complete cardiovascular monitoring was done for the patient, and she developed severe biventricular dysfunction and required high dose of inotrope and ECMO in the postoperative period. She was weaned up from ECMO on day 6. There was infection, renal failure requiring hemodialysis, and prolonged ventilation requiring tracheostomy. and she was discharged on the 40th postoperative day with mild RV and LV dysfunction. The last case is a 32-year-old male and came 6 years post-transplant. He was on PPI and exploratory laparotomy was planned for suspected intra-abdominal malignant mass. Pre-transplant workup was done as per any other patient and pacemaker was evaluated. Endomyocardial biopsy was taken. There was no sign of rejection. Preparation and monitoring was same as any of the other cardiovascular cases because we suspected this case will last long. So again, this patient was done under general anesthesia. The surgery lasted for 4 hours long. This patient needed the vitamin 5 per kg while coming up. On-table extubation was done for this case and the post-op was uneventful. So there is some literatures are available and the author said both for emergency and elective abdominal surgery, there is not much of difference, but however a bit higher incidence of morbidity in the cases who come earlier for in the post-operative period and for the major surgery. So to conclude, a complete understanding that the transplanted heart has blunted sympathetic and parasympathetic innervation. They are more prone for the atrial fibrillation and flutter. This is a very important thing. They are preload dependent, so one has to maintain the systolic blood pressure and give volume because the systolic blood pressure is the only thing you can monitor and know the volume status if you don't have any other monitoring like echocardiography. These other patient again does not respond to the anticholinergic agent and anticholinesterase. So use ephedrine or isoprenaline when there is an emergency. And one has to remember the major side effect of the immunosuppressant drug therapy and the effect on the anesthetic agent so that you can titrate the drug effect. Continue the immunosuppressive therapy in the post-operative period as well. And proper risk stratification in the pre-operative period and team communication and discussion with the patient relative. It is very, very important. Regarding you have to discuss regarding the outcome and the anesthetic technique you are going to employ and what are the vascular access you are going to do and what monitoring you are going to do and how much time the monitoring is required, what are the complications the patient can face in the later on. All these things need to be discussed among the team members and the patient's relatives also so that they can be mentally prepared if any post-op mishaps happen. So thank you so much.
Thank you, Minati madam, for that excellent talk. It was very informative and educative. And thanks for including those cases also. And I'm glad that all these 3 talks will be there forever on our YouTube link. Ma'am, just I want to ask, why did you do that appendicectomy under spinal anesthesia or under regional technique?
Spinal anesthesia because actually that is the first case I did. And I was not very comfortable, honestly, say with the spinal anesthesia because we don't know that case all of a sudden came in emergency and we didn't know how the patient is going to behave because that patient was very unstable. We don't know how the patient is going to behave after the spinal anesthesia.
Okay.
So that was one of the reason. Another reason was the patient was a bit apprehensive and we has to do the first surgery. So that is the reason we picked up the patient for GA.
Anyone on the forum like Kathir sir or Shiv sir, do you have any experience managing such cases?
Minati, you can stop sharing the screen. Yeah. We don't get.
So
Yeah, I've done only one case, dealt with one case of post-cardiac transplant. We don't get many.
Okay, okay.
Kathir.
yeah, we do a lot of cases post-heart transplant. We do around 40-50 transplants per year.
Okay.
Once you establish a kind of protocol, it's not that difficult. People, the question comes up is, I don't know how you guys do Minati, do non-cardiac anesthesiologists manage these cases, or it's only cardiac anesthesiologists do these cases when it comes for non-cardiac surgery?
Non-cardiac anesthetist for us.
Yeah, I think it can be done by anybody. It's as long as they know the physiology. I mean, all these lectures and PBLDs help in non-cardiac team members understand the implications of it. And once you know the implications, it's pretty straightforward. It's more complicated, maybe the patients with the LVAD. Nowadays, they are more frequently present for non-cardiac surgery. They can have a little more complicated. Still, in our setup, non-cardiac anesthesiologists do all these cases.
Yeah, I mean, the only thing I think people need to remember that this is a denervated heart, and you need to use adrenaline as your first choice of, vasopressor or inotrope. You can't be giving ephedrine and stuff like that. So just go for adrenaline straight away.
Yeah.
Sir,
Yes.
so should we wind up like?
Yeah, if anybody got any comment or want to actually, that's it before we wind up. I think all the three lectures and sessions have been, I think, very useful, I think, for everyone. And I think we can have some more later on. I think very informative, all very, very informative talks, I think. And like I said, this is not the end of the symposium here. People can post their questions on our Facebook group, and also the lectures will remain forever till we do similar ones again, to be replaced by the newer information and knowledge. Till then, I think bye to everyone.
Yeah.
Thank you, sir. Thank you.
Yeah.
Bye.
Thank you, Amarja, for organizing. Thank you, Shiv. Thank you, Minati and
Sir.
Akhilesh.
Thank you, Minati madam. Thank you,
Yeah.
Akhilesh, and thank you, Shiv sir, for the opportunity.
Yeah, and at this time of the night, there are 170 odd views, so that's pretty good actually for the whole thing. Yeah.
Nice.
Okay. See you all.
Thank
Good night. Bye. Bye.